speakers. We have 4 talks today. We will be missing the talk on Kenya, but the first talk, each talk will have 15 minutes with 5 minutes for questions. So we'd like to welcome our first speaker, Dr. Sylvia LaCourse, who's acting instructor at the University of Washington.
Let's see. Great. Good afternoon, everyone. Can everyone hear me? Thank you for this opportunity to present. Today I'll be discussing symptom screening for active TB in pregnant women living with HIV, a systematic review. The caveat being these are our early and pilot findings, so hopefully next year when I come, I'll tell you what our finalized findings are. I have no conflicts of interest. And I probably don't need this slide in this room, but it's always important to start from the beginning. So identifying TB is important in pregnant people living with HIV. And it's important for a number of different reasons. First of all, it's more common than we think. And so the TB burden is high in pregnancy. And a few years ago, there was this fantastic modeling paper that estimated that there are over 200,000 cases per year during pregnancy. And again, that's per year. And the highest burden was in sub-Saharan Africa. So it's common. Number 2, potentially pregnancy itself or the postpartum period are a time of increased risk. So it's common and potentially pregnancy is increasing this risk. Number 3, when a mom has TB, it's associated with poor outcomes both for the mom and for the infant. And I'm not going to belabor these points too much and bring up too much data, except something I haven't seen recently presented was this fantastic study that looked at mothers with HIV and TB versus mothers with HIV and no TB. This was a large case control study, and I see some of the authors here in the audience. And they found that with mothers with HIV and TB, their children had 2 times the risk of low birth weight. They had greater than 12 times the risk of infant TB. Maternal hospitalization risk was higher, as well as preeclampsia. And I think the important thing is we've heard this before, but this is now. This is despite widespread ART, the availability of TB treatment, and infant IPT. So this is happening today. This study is not from 10 years ago. So how do we find people with TB? How do we screen for them? Well, the WHO recommends that routine TB screening occur for all people living with HIV. And importantly, they really spell out that this includes pregnant women. How do we do this? We use the 4-symptom screen, which includes cough, fever, night sweats, and weight loss. And why do we use those 4 questions? This symptom screen really has to do double duty. And so what it does is, number 1, it allows us to exclude TB prior to IPT initiation. But additionally, so if somebody doesn't have symptoms, that's really the pathway to they don't have TB and they can initiate IPT. And if they do have symptoms, really that's down the pathway that they need further workup for TB. So we're really asking the symptom screen to do 2 things. So where does this data come from? Why do we use the symptom screen? Well, Dr. Gedahun right here was one of the lead authors on this paper. This was a large individual patient data analysis where they looked at a number of different combinations of symptom screening, and they found that this combination of either having a cough, fever, night sweats, or weight loss had a 79% sensitivity and a 50% specificity for identifying those people living with HIV who had TB. And importantly, when we're thinking about large population screens, what we're really interested in is negative predictive value. And so with this set of questions, it had a high negative predictive value. And you can see at different prevalences that this was really in the high 90s. Importantly, these were people with HIV. However, they were ART naive, and they were just coming into care. So that's important to think about. While we were collecting this data and working on this study, actually some new data came out about how does this symptom screen work in people living with HIV who are actually on ART. So now that ART is being rolled out, how does that symptom screen work in that population? And it's interesting because there are some shifts with somewhat lower sensitivity, but potentially higher specificity. So what I'm going to be talking about today is TB symptom screening, specifically in pregnant women living with HIV. And there's been some signals that this screen may perform differently in this population. And so in initial data at the time, around in 2011, there was some initial data suggesting that the symptom screen had a sensitivity about 55%, specificity of 91%, and again, a relatively high negative predictive value. But recent data suggests it's potentially even further reduced sensitivity in pregnant women living in HIV. So let's just look at these patterns together. So you can see on your left, in general, people living with HIV in the pre-ART era, relatively high sensitivity, some lower specificity. And then at that same time, in pregnant women living with HIV, with getting some ART specifically for prevention of maternal child transmission, a much lower, it's almost like you could flip-flop these graphs, right? And so lower sensitivity and higher specificity. But let's look at the more recent data. Now the sensitivity is really being reduced, and specificity, you can see, is relatively the same. And just to round this out, again, this is recent data that's just come out. How does it look like in people living with HIV on ART? So what we really wanted to probe is how the WHO for symptom screen works in pregnant people living with HIV. And the nice thing is there's actually a fair amount of data out there, so we could actually do a systematic review and potentially a meta-analysis. So to do this, what studies were eligible? Well, they had to have a couple of different things. They had to have enrolled pregnant women living with HIV, not yet known to have TB. Those women had to undergo the WHO symptom screen. And these studies needed to have active TB as defined by culture or expert. That first study I showed from 2011 that had data for pregnant women living with HIV, that included a composite outcome, including both clinical TB as well as some culture-confirmed TB. We included studies that were cross-sectional, cohort, observational studies, RCTs, and we actually also wanted to include case control studies if they were out there, just because we really wanted to get the breadth of information. We did an electronic search. We had no restrictions in terms of date or language. Additionally, we identified studies through conferences such as this. We were very rigorous. We had 2 separate reviewers go through all titles, abstracts, et cetera. And data abstraction was done by 2 separate reviewers. And then if anyone was an author of a study, they would recuse themselves. And in terms of analysis, we calculated individual sensitivities and specificities for these studies, and then did a meta-analysis using bivariate random effects model to estimate our pooled sensitivity and specificity. Because really, there's more power in blending this data together. This flow shows the number of records that we identified all the way down. So we started with, there were 525 records identified. You can see many records were excluded. They didn't meet our initial inclusion criteria. 48 underwent full text reviews. And additionally, we identified 3 other conference abstracts. So 51 articles were assessed for eligibility. You can see we needed to exclude many articles for the reasons shown here. And in the end, there were 5 studies included in our review. We had pretty strict criteria. It's important to remember you needed to have the WHO for symptom screen, and you needed to either have culture-confirmed or expert-confirmed TB. So really, there's likely additional studies that require data from authors. So if I've written you an email recently, please answer back. We want your data. So in the end, in terms of the included studies, you can see that there were 5. Really, they were all based in sub-Saharan Africa. A couple of notable points. The first study you can see there, it included both pregnant and postpartum women as an aggregated population. And additionally, the third study, Hoffman 2015, this was a case control study. So they had cases that were known TB patients, but then they also had a control arm. And in that control arm, they actually identified additional women who were diagnosed with TB that weren't known to have prevalent TB at the time. So what we wanted to do is take the data from that control arm. A couple of interesting points. You can see these were relatively immunocompetent women, right? You could see the median or mean CD4, all over 300, many over 400. And also interesting to look at is the proportion of these women who were on combined antiretroviral therapy. An important factor to see is that the prevalence of TB was relatively high, and it ranged anywhere from 2.5 to 6%. So now let's get down to the question of how did this, for the WHO for symptom screen, how did it actually perform in this population? So when you look at these estimates, you can see the ranges of sensitivity and specificity. And when you pool these estimates, the pooled sensitivity, so the performance of the WHO symptom screen for sensitivity was 22%, with a pooled specificity of nearly 84%. We wanted to do a sensitivity analysis. So as I mentioned before, there was that one study that was a case control study. And so we said, well, let's remove that and see how that affects our estimates. Again, the pooled sensitivity was really quite low, so about 26%, with a pooled specificity of about 84%. So when you're thinking about negative predictive values, because again, this is a screening test, so people are always thinking about, on a population level, what's the negative predictive value? So assuming a TB prevalence of around 1%, the negative predictive value was 99%, and assuming a TB prevalence of 5%, the negative predictive value was around 95%. I like showing these numbers in context. So what you see is in the dark blue, I don't know if I can, oh, here we go. So this orange box right here, that's really the summary estimate of all of this data in pregnant women living with HIV. And just as a reminder, here is the summary estimate of how the WHO for symptom screen works in people living with HIV who are ART naive. So a much higher sensitivity, although lower specificity. And again, in this more modern era of people living with HIV on ART, you can see again a reduced sensitivity, but a higher specificity. So I show this graph because I've always wondered, well, does the symptom screen potentially not work that well in pregnant women living with HIV in the current era because most of them are relatively healthy and they're on ART? Is that the signal that we're getting? But this would say that that doesn't necessarily seem to be the case. There is something different about this population other than people living with HIV in general who are ART naive and people living in general who are on ART. So there's something different about pregnant women. The next steps that we want to do is we're thinking about looking at additional symptom or symptom screen combinations to identify women for active TB. We want to look at additional sources of heterogeneity, ART status, CD4 count, gestational age. Does it work different if you're in your earlier stage of gestation or later stage of gestation? What about pregnancy versus postpartum? And also looking at the TB prevalence in the study populations, although you'll see that the prevalence was pretty similar between all of these studies. We also want to look at the assessment of methodologic quality. So what does this mean? Let's just break this down. So the sensitivity of the WHO symptom screen appears to be reduced in pregnant women living with HIV. And remember, this is important because this symptom screen is really your first step that dictates whether or not you're safe for IPT or you need another diagnostic for TB, okay? So theoretically, at a prevalence of 5%, that means out of 1,000 pregnant women living with HIV screened, 13 would be correctly identified with TB, right? Your true positives. 37 would be missed, and 153 without TB would be falsely positive. Let's put that in context with the estimates that were used to identify what question should we use for the WHO symptom screen. So for people living with HIV who are ART naive, at a prevalence of 5%, out of every 1,000 people living with HIV who are ART naive screened, 40 would be correctly identified with TB, 10 would be missed, and 475 without TB would be falsely positive. So what's going on here? What are the potential reasons for this decreased sensitivity in pregnant women living with HIV? Is it that there's been this thought for some time that pregnancy can mask the symptoms of TB? Okay, that's a potential reason. It could also be all of these studies screened everybody for culture and expert, irrespective of symptoms. So maybe we're identifying these women early in their disease course. Are we identifying incipient or subclinical disease? That's potentially the case. I will remind you, really, we're thinking about a mother and a child as well. So even if a woman has subclinical disease during pregnancy, she may clear that infection, right? She may clear that disease or she may clear that infection and not go on to develop active disease. But let's think about that window, what's happening in a short period of time she's delivering and could potentially be infectious. These are just important things to think about. What about the role of ART? It's interesting. So we didn't statistically compare the difference between ART naive, people living with HIV on ART, and pregnant women in general. But really, when you graphed it out, that didn't really seem to be the case. There's something different that's going on in pregnancy that we just need to probe further. And I don't have the answers to these questions, although potentially people in the audience do. So if there's a problem with the screen, or if there is a problem with the screen, how do we improve it? Do we do repeated screening? There's been a lot of discussion recently on how this works when you repeat screening in this population. If women themselves aren't having symptoms, can we ask them, does anybody else in your household have symptoms? Maybe that might be an indicator of exposure and then potentially increased risk of disease. And then this could be somewhat controversial, but what's the feasibility of a single universal sputum testing? Do we need to be doing testing on all of these women? The burden on that on a system would be incredibly high. Although there's a really fantastic study that was we've seen some preliminary data from, that it was universal testing of pregnant women versus symptom-based testing of pregnant women, and they found that universal testing for TB actually had hard outcomes where it reduced both maternal and infant mortality. So it's just something to think about. I'd like to acknowledge all my collaborators. One of the really interesting and fun things about this project is we were able to work with a number of different people. We work with people from Cochrane, CDC, adult ID specialists, people who are methodologists and think about diagnostic tests all the time, neonatologists, TB epidemiologists, and biostatisticians. And I'm probably missing somebody in there. But I think it's really great to work with a group that has a really broad knowledge base. And thank you.
Conflicts of interest. So the World Health Organization estimates that in 2015, of 10.4 million cases of tuberculosis globally, 3.5 million were among women and about 1 million occurred in children. And in the same time period of 1.4 million deaths due to tuberculosis, 496,000 were among women. We all know that despite the scale-up of ART, TB remains a leading cause of death amongst people living with HIV. And as we just heard, in pregnant women, active TB is a risk factor for significant perinatal morbidity, mortality, as well as vertical transmission of Mycobacterium tuberculosis. Now, although the impact of TB on the health of women of reproductive age is well known, TB case identification remains a challenge, as we just heard, and furthermore, access to TB preventive services is suboptimal. Integration of TB HIV collaborative activities into Reproductive Maternal Newborn Child Health Services offers an opportunity to enhance access to TB preventive therapy, as well as ensure timely diagnosis and treatment, improving TB outcomes for women and for children. So ICAP at Columbia University, in collaboration with CDC and the Ministry of Health in Swaziland, is providing technical assistance to enhance existing integrated TB and RMNCH services in select health facilities in Swaziland. And the objectives of this project are threefold. First, to assess the feasibility of strengthening TB-HIV collaborative activities in RMNCH services. Second, to assess the achievements of enhanced and integrated TB and RMNCH services along the TB-HIV cascade for pregnant women and their affected children. And finally, to inform the development of the WHO's toolkit for TB-HIV integration in RMNCH settings. So these enhanced integrated services are being implemented in 4 health facilities in one region in Swaziland. They include a hospital, a public health center within a hospital, and 2 clinics. The average number of monthly antenatal care visits at these 4 facilities ranges between 10 and 90. And at all of these facilities, RMNCH, HIV, and TB services, as well as expert machines, are available on site. ICAP's technical assistance is focused on improving intensified case finding, IPT provision, contact tracing, and infection prevention and control activities, which I'll discuss further in the subsequent slides. In April of 2017, training was conducted on site at each of these 4 facilities for nurses and cough officers. This consisted of 3 half-day trainings that included clinical topics, patient flow, and monitoring and evaluation. At that time, there was the introduction of 3 new tools, including an enhanced RMNCH TB register, a contact tracing tool, and a TB services capacity tool. And then between April and December of this year, we're providing a weekly on-site mentorship for the enhanced service provision. And an evaluation is planned in January of 2018, which will include self-administered questionnaire for healthcare workers on their perceived benefits, or their perceptions, I should say, of enhanced integration, as well as retrospective data collection to assess project outputs and outcomes. So in terms of the activities for intensified case finding, cough officers are present at the facilities, and they offer TB screening to all women and children arriving at RMNCH using the national TB screening tool, which includes the 4 symptoms that you just heard about. And these results are recorded on the screening tool, which is then referred to the MCH nurse. Now, I know it's very blurry and you probably can't see from the back of the room, but the symptoms include unintended weight loss for adults. And ICAP has trained the cough officers as well as the MCH nurses to adapt this screening tool for pregnant women to assess poor weight gain, which is actually what's asked of children in the national tool. All women with presumptive TB are asked to provide a spot sputum specimen for on-site expert testing, and the cough officer will walk that specimen over to the TB lab, the laboratory on site, and then women diagnosed with tuberculosis are escorted to the TB clinic for treatment. Now, the existing presumptive TB register was adapted to include all women screened for TB in the RMNCH setting to allow longitudinal follow-up of the entire TB-HIV cascade. So this is, shows you the two the two pages of the register. So it's one long longitudinal row for each pregnant woman. And similar to the existing presumptive TB register, it collects data on women with a positive screen, including TB investigation, diagnosis, treatment initiation, and outcomes. But it also includes data on women with a negative screen, including IPT initiation, refills, and completion, as well as TB screening at follow-up consultations. So currently in the RMNCH services at these health facilities, this register has replaced the presumptive TB register. In terms of contact tracing, ICAP developed a contact tracing tool which was added to all index case files to allow for identification and follow-up of household contacts during clinic visits. And this is a modification of ICAP's family tree tool, which we use in ART services to evaluate and follow up family members and partners of index cases for HIV testing. And here what we're doing is we're recording data on the partner and the children in terms of TB screening, TB diagnosis, and HIV testing. So this chart is placed into the patient's file so that the nurse can follow up on each clinical encounter. We're also supporting integration of the Ministry of Health's contact tracing register, which is a longitudinal register and allows follow-up of outcomes of household contacts and is good for monitoring and evaluation purposes. And this is just a screenshot of that as well. It includes TB screening, presumptive TB management and diagnosis, as well as HIV testing and IPT information. Now, this integration of contact management in the RMNCH services is new. As you know, what is happening nationwide is that as TB cases are referred to the TB clinic, contact management traditionally happens at the TB clinic. So as part of this project, the contact management has moved to the RMNCH services, and the nurses are responsible for following up and recording the results of contact management. And thus, we've also integrated IPT, eligibility screening, prescription, and follow-up into the RMNCH services. And to do this, we adapted job aids and allocated them at the clinics and are providing training and ongoing mentorship to the MCH nurses on IPT eligibility criteria, as well as use of the register. Isoniazid was allocated to the RMNH services, and prescription and follow-up visits are done by the MCH nurses at the RMNCH sites. And finally, in terms of infection prevention and control, we've trained all providers at the RMNCH services on IPC and have implemented triage and fast tracking for patients with presumptive TB to minimize the time they spend in waiting areas. There's been allocation of patient information and education materials in the waiting areas and in the clinic rooms. And we've identified focal points for IPC at each health facility if one did not already exist. We've also introduced a TB services capacity tool to support the health facility management team to follow up on integrating all TB HIV activities, including IPC. So this is a checklist that the focal point can use on a monthly basis to assess human resources and TB IPC, intensified case finding, diagnosis, IPT, and contact tracing. So because the evaluation is not planned until January, I do not have quantitative data to share with you today. However, I do have some qualitative information about challenges and lessons learned. So we have experienced several challenges in implementation of this enhanced integrated services. The first being challenges with contact tracing. We found that caregivers are often reluctant to bring their children to the health facility to be screened and evaluated for tuberculosis. In addition, we've experienced high healthcare worker turnover at the facilities, which influences proper implementation of activities and has necessitated sort of training almost monthly at least one of the facilities. In addition, initially, there were challenges with supply chain management of isoniazid, and this was because there was actually a tremendous increase in demand for isoniazid that exceeded the expectations of the facilities. But this has been addressed, and there's adequate supplies at the RMNH services at all facilities. In addition, the increased number of registers and workload has led to some constraints in data quality, and a real focus of the ongoing mentorship visits has been on sort of data quality assurance and ensuring proper register completion. And finally, for some providers, there's been a reluctance to change their perception around services, and this specifically relates to a sort of hesitation on the some providers in providing isoniazid and concerns about side effects and toxicity, particularly in a pregnant woman. There have been a number of lessons learned. First, we've realized that integration of TB-HIV activities into RMNCH services is possible, particularly ensuring TB screening and IPT provision for pregnant women. And the MCH nurses are really pleased that they can provide more comprehensive care, a more comprehensive package of care for their patients. We found that at high-volume sites, adding human resources, so lay personnel, is really essential to ensure proper implementation and continuity of the interventions. So utilizing the cough officers or mentor mothers to do the TB screening, to transport the specimens and escort the patients, as well as to help with register completion. We found that in order to improve contact tracing, it's important to ensure linkage with community services that allow for outreach and TB screening closer to home. So that initially can be done as a home visit, although in Swaziland it is guidelines that children under 5 that are household contacts should be evaluated in a health facility because they're considered to have presumptive TB. And finally, to reduce the burden of extra documentation, there needs to be identification of key variables that are in these TB RMNCH registers that could potentially be incorporated into the existing ANC and PNC registers. And this will improve both data quality and likely also better service integration. So I would just like to finish by acknowledging the many people involved in this project at ICAP, both at Columbia University and in Swaziland, as well as our donor and collaborator at CDC at headquarters in Atlanta, as well as in Swaziland, and our collaborators in the Ministry of Health. And I'd be happy to take any questions. Thank you.
You just put it like this? No, forward, backward. Okay.
Good afternoon to you all. I'm going to be switching a bit of gears from pregnant mothers and children to the children in outpatient clinics. And this is some work that we have been doing for some time with a group of colleagues. We are trying to look at evaluation of TB in the outpatient in children in some primary care clinics within Kampala. Just an outline of my presentation. As a background, TB is often missed in children. Globally, about 2/3 of the children are either undiagnosed or not reported. In Uganda, we see that more than 50% of TB cases are not reported or diagnosed. And this is mainly because of the difficulty of diagnosing TB in children, and to address that, the International Union Against TB and Lung Disease and WHO introduced a desk guide. And this desk guide is aimed at helping us make sure that we can diagnose TB easily, both clinically and also using the gene expert. So we use these desk guidelines and try to assess the quality of TB diagnosis, looking at that cascade within the primary health care clinics, within 6 clinics within Kampala. And this is the desk guide outline. It shows children who are suspects, then, and those who have symptoms and probably have a contact, and those are presumed to be. Then those need to undergo evaluation, and then diagnosis and reporting and treatment. So this is the algorithm of the desk guide, which has gone through a number of versions, and there are some few changes. So between November 2015 and December 2016, we conducted a cross-sectional study here in children less than 5 years who are attending OPDs at 6 primary healthcare clinics within Kampala. So clinician completed a standard patient record form, which they use, and that record form clearly stipulates what are the signs and symptoms, and when to refer the child for TB evaluation. So looking at that desk guide, we came up with some performance indicator that for every child who comes in the OPD should be screened for symptoms or contact with a TB case. And that's some of the questions that is on that outpatient form. And once a child has any of those, he screens positive, he should be referred for TB lab evaluation. And then every child who is found to be positive should also be tested for HIV and treated for TB if positive, or meeting a clinical criteria as outlined in that desk guide. So in the results that we found, we really evaluated a number of children over that period of time, about 24,000 children, and we found that more than 50% were not screened. They come in the OPD, but they are not screened. So there is a major gap in screening whoever comes in. So when we looked at among those who had presumptive TB, those who screened positive, they either had the symptoms or they had history of contact. Almost 80% were not referred for further evaluation. So when we looked at the children who ended up meeting the criteria for a diagnosis of TB, those are children who are either positive from the lab. Among those who are 20, 60, almost 80% were not treated within that short period of time. Maybe over time, some of them may have been treated. So there are big gaps in those areas. And so we looked at the issue of really children are supposed to be screened for HIV according to the guideline. Found that these were children who had presumptive TB based on either screen positive or history of contact, and all these children were not referred for HIV testing. A major gap there. And similarly, when we looked at 18% were not tested for HIV, despite being referred to go for testing because of different reasons, they were not tested. So, really, you see that in summary, there are major gaps in that cascade of evaluation of children within the OPD. And thus, there is need for various interventions. So, in conclusion, there are large gaps that exist in routine TB evaluation for children. There's a need for enhanced implementation of screening, testing, diagnosis, treatment of children for TB, offer major opportunities to improve diagnosis and outcomes of TB. And based on those gaps that we have found in different areas, there are providers, there's the health system, and there's also the patient. So we have moved forward to build on this work to try to find out what are the barriers, what are the facilitators for these different processes, so that we have come up with some interventions to try to address those barriers and test them, and then later on try to understand how we can improve that if we are to improve TB care in children. So this work, I would like to acknowledge a number of people who have, this work has been mainly funded by USAID, Washington, and other grants, which some of the trainees who are working on this project are funded by some other training grants, which are based at Makerere University. Thank you.
Thank you very much. Any questions? And the questions can actually also be for the previous presenters, if you have any leftover question. Abhinash.
Hi, thanks for the presentation. So the question is, I mean, it's important work, and you identified the dropouts, but the major one is the first step, 52% not screened. So what is the reason you found? Is it because of lack of knowledge, or is it the workload, or is it something else? Why so much dropout at the first step?
Yeah, probably that's some of the things that you, for example, we looked at now, this is data that you find in routine care, and you collect that data. That data, we've analyzed it and found that's the gap. Now, we have interviewed clinicians to find out why is the gap. One of the gaps that we found at that point was that the recording per se that was in place to capture this information, we do not have proper recording to capture all this different information. And also, in addition, the burden of some of the symptoms which could be done at an outpatient basis by, say, someone, health educator, to screen for some things and refer them. So that whole burden is not to the clinician. Similarly, there are a number of forms that are used in the outpatient, and you find that the information may be there, but there is a request form which goes to the lab, does not come back. If it comes back, it's a loose paper. So in that case, we devised and created one patient record form which really captures all the information, and the patient moves it to the lab and other things, and also ensure more supervision of that work. Another thing that we have tried to institute is really feedback, so that this data, as it's being collected at a routine basis, the clinicians within the clinic can share this information and look at the gaps of the different indicator levels and review and improve over time.